Solid breast nodules, benign versus malignant. If we look at the type of cancers that we see with ultrasound, the number one cancer that we'll diagnose is invasive ductal carcinoma. You can see the second most common is invasive lobular. We also have medullary, mucinous, DCIS, and other types in metastasis. DCIS is much more common in the mammographic role, but with ultrasound, we typically will find invasive ductal cancer most often. Now, just the opposite of our judicial system, with breast sonography, what we want to do when we find a solid lesion is think of it as being something worrisome. So the first thing we're going to do is seek malignant findings. Once you have looked for malignant findings and you haven't seen any, then what you want to do is make sure you can classify the lesion as being benign. If you cannot classify it as being benign, then we have to classify it as indeterminate, and if it's indeterminate, it's recommended for a biopsy. Breast cancer is extremely heterogeneous. It's very important to make sure that you scan the entire nodule in two planes, looking for any subtle changes that you might see. If you happen to find a mixture of benign and malignant findings, it will exclude the lesion from being benign and classify it as being something worrisome for malignancy. And I already mentioned the heterogeneity of breast cancer, not only from nodule to nodule, but often within a single nodule, we'll see very heterogeneous findings. If we look at this chart, you can see the heterogeneity of breast cancer. We've got one end of the spectrum where we'll have lesions that are very well circumscribed. On those, we'll see lesions that are extremely cellular. You may have high-grade lesions, ones with an inflammatory reaction, enhanced through transmission. These are ones that are positive on color Doppler. On the opposite end of the spectrum, we have our spiculated lesions. They tend to be more paucicellular, they're low-grade cancers, they host a desmoplastic reaction. We'll see shadowing behind those. These are typically negative with color Doppler. And because of the heterogeneity of breast cancer, often we have a mixture between these two findings that we'll see within a single lesion. Looking at solid nodules, the complex spectrum of the gross morphology, we can see lesions that are fairly well circumscribed, that are malignant, and then we have lesions such as fibroadenomas that can be extremely worrisome looking, especially if you're scanning a young teenage patient, more often in black females. They can have what are called juvenile fibroadenomas. Those look very worrisome sonographically. And then we have things such as radial scars that present as spiculated lesions that we really won't talk about much today. Now, if people sometimes think that we should not use ultrasound to try and differentiate benign versus malignant lesions, they say if you took a single finding, you can see, such as shadowing, how many fibroadenomas that we could prevent a biopsy in the area of green, but you could see how many false negatives that we would have in the area in red. But with ultrasound, we don't take just a single finding, we take multiple findings. We apply basically the same algorithm that we do with mammography. And what we're able to do by doing this is get our false negative rate less than 2%, which is pretty much the gold standard for mammography. So with ultrasound and using these multiple features, we're able to get our false negative rate of less than 2%. These are the different things that we will talk about. Features of breast cancer. We can look at spiculation, angular margins, and acoustic shadowing. These are what I call hard findings. They tend to go along with an invasive process. More nonspecific findings, in other words, can go along with either invasion or DCIS, are microlobulation, taller than wide, and looking at the echogenicity of the lesion. We compare all lesions in the breast to fat. So if I say a lesion is hypoechoic, that means it is darker than fat. More soft findings that tend to go with DCIS are things such as duct extension, branch pattern, and calcifications. So the first feature that we'll look at are spiculations. This is more of a hard finding. Now, depending upon the background of the tissue surrounding the lesion, we may see hypoechoic spicules. If there is an echogenic, more of a fibroglandular background, we will notice hypoechoic spicules. If the lesion is surrounded by fat, the spiculations that we'll see will tend to be more echogenic. These are the ones that show up mammographically because we've got a fatty background, so on mammogram we can see those type of spiculations. If we look at the image on the left here, in this particular breast cancer we have an area of duct extension. This cancer is also taller than it is wide through this portion, and here you can see these hypoechoic spicules radiating out because there is an echogenic background. You also notice that there's a smaller cancer sitting right here, a multifocal lesion. If we notice the image on the right, these are more echogenic spiculations that we can see radiating out because there is a fatty background. So since we have the fatty background, we can see echogenic spiculations versus the hypoechoic ones when we have the bright background. Because of the heterogeneity of breast cancer, sometimes only a certain surface of the lesion may have spiculations, and here we can see spiculations on the anterior surface and appears a little bit more like thick halo around the lateral side of it. Why is it sometimes that we see echogenic versus hypoechoic spiculations? Actually, we have both of them present, and typically the background tissue will alternate or will eliminate one of those. So if you notice, here is the actual spicule, which is more hypoechoic, which is we're seeing here on this pathology specimen, the spiculation. The interface between one spicule and the other is more of the echogenic background. So this is a nice example of being able to demonstrate both hypo and hyperechoic spiculations, and typically we'll only see one of those when we do our imaging. One thing that's very important when you are looking at a lesion, make sure that you optimize the image completely. When you first start scanning, you want to make sure you take a picture that you can see all the way from skin surface down to the chest wall. But once you're ready to look at that, look at the surface characteristics of this lesion, make sure that you zoom up, and here you can see these spiculations much better on a zoomed image. So optimize your image completely when you're looking at it. A variation of spiculations are what we refer to as the thick echogenic halo that you can see surrounding this lesion. Now, one thing that we'll notice is the thick echogenic halo a lot of times will appear to be thicker on the edges than it is on the anterior and posterior surface. So usually it's thicker on the anterior and posterior, thicker on the edges than it is anterior and posteriorly. This is the same lesion that was scanned the same day. The only difference is that we can see this image on the left was done on a mid-range ultrasound equipment versus scanning it on a high-end equipment. So what appears to be a thick echogenic halo seen here are actually individual spicules that we can see radiating out once we used our high-end equipment. I think both of the systems will show that this is a lesion that needs to have a biopsy. It's just if you're using high-end equipment, you can make your diagnosis with a lot more confidence, I think, using high-end equipment. Now, the next finding we're going to talk about are angular margins. Angular margins are a hard finding, so if we see this, we typically are dealing with an invasive carcinoma. You can see this lesion here, all the multiple angular margins that we're able to demonstrate. Also notice that this lesion is markedly hypoechoic compared to the fat. There's some areas of calcification with it. There's enhanced through transmission behind it. So most malignant lesions have multiple features that we will be able to see in evaluating them. Because of the heterogeneity of breast cancer, it's very important to make sure that you scan a lesion all the way through in two planes. Don't just take one random cut transverse through here and another one longitudinal through this plane, or you will miss the angular margin seen here or the microlobulation seen in this area. So very important to make sure you scan all the way through and look for these subtle little changes that we might see on ultrasound. Looking at this cancer that we can see, I'm going to show you a dotted line and a dashed line right through the cancer that's just about 1 centimeter apart from each other. Notice on this image on the right through this area, how well circumscribed this lesion can appear. Whereas a cut just about 1 centimeter away, there are obviously malignant features, angular margins and shadowing that we can see. That's just showing you or demonstrating the amount of heterogeneity that we can see within a single nodule. Now, in looking at breast cancer, cancer likes to take the path of least resistance. So as a cancer becomes invasive and starts to spread, a lot of times what it'll do is when it hits up against this anterior premammary fascial layer, the anterior premammary fascial layer comes along wherever there's a Cooper's ligament, it goes up, attaches at the skin, and comes back down. So as cancer starts and hits up against that premammary fascial layer, a lot of times it will start invading up through Cooper's ligaments. And one thing we learned is if we're looking for subtle changes on cancers that are fairly well circumscribed, is look into the area of a Cooper's ligament, and that is where we'll be able to find these little angular margins right in that area. They tend to invade Cooper's ligaments. So looking at this cancer, one thing you'll notice is wherever we have a Cooper's ligaments in the base of it, we can see an angular margin. So angular margins is everywhere there's a Cooper's ligament attached. The cancer likes to take the path of least resistance when it starts to invade. Our next feature that we're going to look for is microlobulation. That can go along with either invasion or DCIS. Different ways that it can present. You can have fingers of invasive tumor. We can have intraductal components or actual cancerization of the lobules. If we look at the invasive fingers of tumor, sort of an angular or also associated with the thick echogenic halo, you can see right through here we've got those areas, and very similar to what we would call sort of spiculation within that, but those are the fingers of invasive tumor that we'll see with microlobulation. Looking at microlobulation, the DCIS components of the tumor are in this area here that are highlighted. 85% of ductal cancer is in mixed invasion and DCIS. The invasive chords tend to be more centrally located. The DCIS tend to be more peripherally. This is why it's very important when a lesion is biopsied that different areas of the lesion are biopsied and not all of them right through the same area. If you got a sample back of just DCIS, treatment for the patient is much different than if they know that it is an invasive carcinoma. So very important to take different samples through a lesion when a biopsy is performed. And the last part of microlobulation is cancerization of the lobules. You can see here that we have the TDLU cancer within the lobule itself. Now, depending upon the nuclear grade of the cancer, your low nuclear grade lesions tend to have small microlobulation. Your high-grade lesions tend to have much larger microlobulations. Also notice with your high-grade lesion that you have enhanced through transmission that we can see behind the lesion. Very important to make sure, once again, that when you're looking at lesions, this lesion may appear to be fairly well circumscribed, but once we zoom up, notice how you can see these little areas of microlobulation. So be sure, optimize your image completely every time that you're looking at it. The next feature worrisome for malignancy that we're going to talk about is if a lesion is taller than wide. So when it's taller in the anterior and posterior dimension versus a transverse dimension. So a finding that tends to be more with benign lesions or when a lesion is wider than tall, seen in the fibroadenoma. Small cancers, sometimes we will see growing in a taller than wide appearance. So here we've got the wider than tall versus taller than wide. Tends to be more of a benign finding. This tends to go along more with malignant findings.